This next recording is going to look at the extrinsic regulation of the heart, which looks at how the autonomic nervous system and hormones affect heart rate, heart stroke volume, cardiac output, and MAP. So the autonomic nervous system can affect the heart rate, and in affecting the heart rate, it's going to also affect cardiac output and mean arterial pressure. Remember that mean arterial pressure is dependent on cardiac output and peripheral resistance, while cardiac output is a parameter of heart rate and stroke volume. So if we substitute heart rate times stroke volume for cardiac output in the MAP equation, you can see how heart rate and stroke volume and peripheral resistance are going to influence MAP. An increase in heart rate is said to be a positive chronotropic effect. Chronos means time. It's referring to the fact that when you increase heart rate, you're increasing the number of beats per minute. So you're increasing how fast the heart is pumping. In increasing contractility is said to be a positive ionotropic effect. Iono is for ions, because in order to increase the force of contraction, there has to be an increase in the influx of calcium ions into the cardiac muscle. And that's what's going to result in an increased force of contraction. Remember from last semester, chapter 9 on muscle physiology, calcium was the ion that made possible the cross bridges in the sarcomere that created muscle contraction between myosin and actin. So calcium ions are needed to increase contractility of the heart. So increase in heart rate is said to be a positive chronotropic effect. Increased contractility is said to be a positive ionotropic effect. So an increase in contractility means an increase in the force of contraction, which means an increased force with which blood is pumped out of the heart. So it's an increase in stroke volume. Positive ionotropic effects are given by agents that allow more calcium ions into the heart muscle. And that's what's going to increase the force of contraction or contractility. The sympathetic nervous system increases heart rate and contractility, that is force of contraction. Their force is going to increase heart rate and stroke volume. Sympathetic stimulation has a positive chronotropic and ionotropic effect on the heart. Epinephrine and norepinephrine hormones have a positive ionotropic effect and chronotropic effect, just like the sympathetic nervous system. That's why we call epinephrine and norepinephrine sympathetic hormones. So you should know the effects of the sympathetic nervous system on heart rate and stroke volume, and the effects of the hormones epinephrine and norepinephrine on heart rate and stroke volume. On the other hand, the parasympathetic nervous system is going to decrease heart rate. So that is a negative chronotropic effect. There is no direct effect on force of contraction. Parasympathetic stimulation only has a chronotropic effect. It has no ionotropic effect. However, in other words, it doesn't affect stroke volume. However, not directly. In decreasing heart rate, by default, the stroke volume will be increased indirectly, because if we decrease the heart rate, the ventricles are going to be contracting in the contractile stage for a longer amount of time. So systole, ventricular systole, is going to be longer if we decrease heart rate, which means there's more time to pump more blood out. And that's why stroke volume will increase when we decrease heart rate. So a decrease in heart rate has by default, not directly but indirectly, an effect of increasing stroke volume. So a decrease in heart rate gives us more time to pump blood out, which means we're going to end up pumping more blood. So there will be an increase in stroke volume. So this is an important point. Parasympathetic nervous system does not affect stroke volume directly. It affects the stroke volume by slowing down the heart rate. Therefore, there's more time to pump blood out. So the factors that affect MAP by affecting cardiac output will be an increase in sympathetic stimulation, which in turn decreases parasympathetic stimulation. You can also have an increase in epinephrine and norepinephrine hormones from the adrenal medulla. Any one of these two events, increase sympathetic stimulation or increase epinephrine and norepinephrine, will increase the heart rate, will increase the contractility. Increasing the contractility increases stroke volume, which increases cardiac output. Increasing heart rate also increases cardiac output. Increasing cardiac output is going to increase mean arterial pressure. Parasympathetic stimulation, on the other hand, is only going to affect heart rate, as we mentioned earlier. Cranial nerve number 10, which is vagus nerve, innervates the SA node, sinoatrial node, and the AV node, atrioventricular nodes. It also innervates the atria, the myocardium, and some coronary blood vessels. Parasympathetic stimulation lowers heart rate, indirectly affecting stroke volume when you lower the heart rate. So there's an indirect increase in stroke volume. Acetylcholine is the parasympathetic neurotransmitter. Acetylcholine in the heart binds to potassium channels and allows and keeps them open longer, allowing for more potassium to escape, making the cell more negative and effectively hyperpolarizing the cell membrane. So parasympathetic activity has no direct effect on the stroke volume because the vagus nerve does not innervate the ventricles. It only innervates the SA node, the AV node, and the atria. Parasympathetic innervation has an indirect effect on the stroke volume. Low heart rate increases filling time, increasing the stroke volume. So you should be able to explain the differences between parasympathetic and sympathetic activity on the heart. The sympathetic cardiac nerves have a more thorough innervation of the heart. They innervate the SA node, the AV node, the atria, and the ventricle myocardia, and coronary blood vessels. So the differences here is that parasympathetic innervation does not innervate the ventricles. The sympathetic nervous system does innervate ventricles. An increase in heart rate between 250 and 300 beats per minute, and increases contractility so that the force of muscular contraction increases stroke volume because the heart is pumping stronger, more blood is pumped out. However, as we increase heart rate beyond 250 beats per minute, it will be very hard to increase stroke volume because after that point, the heart is beating so fast that there's little time, even though it's beating stronger, there's little time to pump blood out. So actually stroke volume after 250 beats per minute is not going to increase. So this is beyond the limit of, beyond this limit, the heart rate is too high to increase the stroke volume. So that's important to remember. Heart rate, an increase in heart rate and an increase in contractility will increase stroke volume as long as the heart rate stays between 170 and 250 beats per minute. Anything above 250 beats per minute, the heart is beating too fast to pump enough blood out. Therefore, stroke volume is going to decrease, not increase. So sympathetic stimulation maintains ventricular contraction strong. A norepinephrine, which is the sympathetic neurotransmitter, increases heart rate and the degree of depolarization of the heart because it increases calcium influx into the heart muscle. This increases the force of contraction and heart rate. Hormonal control is through epinephrine and norepinephrine, and they have the same effect as the sympathetic nervous system. The only difference is that in the case of hormones, the effects are going to last longer because it takes it a long time for the body to get rid of hormones. So this is an important picture. It's showing us several points that we've talked about and some that we haven't discussed yet. Notice the green lines. Those represent sensory neurons that are bringing sensory information to the medulla oblongata, where there is a cardiac center. So we have branches of two nerves that are collecting information from blood vessels. Cranial nerve number 9, glossopharyngeal, is bringing information from baroreceptors and chemoreceptors in the carotid arteries. These are called the carotid bodies. So this is cranial nerve number 9, glossopharyngeal nerve. On the other hand, cranial nerve number 10, vagus nerve, which is a mixed nerve, is bringing information from what we call the aortic bodies, and these are baroreceptors. So they're giving information about essentially blood pressure, whereas chemoreceptors give information about things like pH. So those two are going to take this information and carry it to the medulla oblongata, which is the control center for cardiovascular regulation. In response to the information being brought in by cranial nerves number 9 and number 10, the medulla puts out a response. If a parasympathetic response is needed, parasympathetic innervation via cranial nerve number 10, vagus nerve, is going to reach the atria, the nodes, and the myocardium of the atria. If a sympathetic response is needed, now we have a more thorough innervation because the sympathetic nervous system is going to also innervate not just the atria but also the ventricles. At the same time, sympathetic stimulation will stimulate the medulla, the adrenal medulla, into secreting epinephrine and norepinephrine, which are going to travel through circulation, reach the heart, and have the same sympathetic effect as the sympathetic nervous system. So at this point, you should know the effects of the sympathetic nervous system on the heart and the effects of the epinephrine and norepinephrine sympathetic hormones on the heart. And keep in mind, they're both the same: increased heart rate and increased contractility of the heart. the parasympathetic nervous system on the heart is going to decrease heart rate, and in doing so, it's going to indirectly increase stroke volume. You should know the parts of the heart innervated by the sympathetic nervous system and the parts of the heart innervated by this parasympathetic nervous system. Heart and homeostasis refers to manipulating heart rate in order to keep cardiac output within homeostasis. The part of the brain that is in charge of day-to-day, minute-to-minute homeostasis is the medulla oblongata. So, cranial nerves number 9, glotopharyngeal, and number 10, vagus, are constantly monitoring blood pressure in the carotid artery, in the case of glotopharyngeal, and aorta, in the case of the vagus, and this blood pressure information is being sent to the medulla oblongata, where there is a cardiovascular center. Normal blood pressure fluctuates between 80 and 120 millimeters of mercury. If the pressure goes beyond or below, above or below these parameters, the medulla oblongata will respond using parasympathetic or sympathetic stimulation to bring the body back to homeostasis, to bring the heart back into homeostasis. So, let's look at examples on how this happens. Okay, if there is an increase in blood pressure, cranial nerves number 10 and 9 will detect this because the cells, the baroreceptor cells in the carotid artery and the aorta will be stretched by the high blood pressure. And that will be communicated via, to the medulla oblongata via cranial nerves 10 and 9. And in this event, the cardioinhibitory center of the medulla oblongata will be stimulated by this high blood pressure message. The cardioinhibitory center is going to increase parasympathetic stimulation, while sympathetic stimulation will decrease. Parasympathetic stimulation, in turn, increases the heart rate, decreases the heart rate, which in turn is going to decrease cardiac output and bring the body, the heart, the blood pressure back to normal. So increasing blood pressure stimulates parasympathetic stimulation to decrease heart rate and lower blood pressure. On the other hand, if we have low blood pressure, the baroreceptors will not be stretched, and that again will mean that cranial nerve number 10 and number 9 will signal the cardioacceleratory center to respond. The cardioacceleratory center is going to inhibit parasympathetic stimulation, but it's going to stimulate the sympathetic nervous system, which is going to increase heart rate and stroke volume, increasing cardiac output, and increasing blood pressure. So you should know the effects, the response of the medulla to an increase in blood pressure or a decrease in blood pressure. And hopefully all this makes sense. So you should know the location of these baroreceptors and the cranial nerves that relay blood pressure information to the medulla. You should know the medullary response to an increase in blood pressure or a decrease in blood pressure. Now, we haven't talked about the chemoreceptors, but the chemoreceptors are going to detect changes in pH and in carbon dioxide in the blood. So that if there is an increase in carbon dioxide on the blood, the response is going to be to increase heart rate in order to pump more blood to the lungs and breathe the carbon dioxide out. A response to low carbon dioxide will stimulate parasympathetic nervous system to lower the heart rate and keep more of the carbon dioxide in the blood. And finally, we're going to look at abnormal conditions and aging. The kind of changes that are seen in the heart due to age is the stiffness of the aorta, which is going to increase blood pressure in the aorta, which is going to increase the afterload. Increasing the afterload over time makes the ventricles work harder because it takes them more force and more time to open the aortic semilunar valve. And that's going to end up hypertrophying the left ventricle. The left ventricle will become bigger. There's going to be a slowing in heart rate, and there's going to be an enlargement and thickening of the heart muscle. If there's coronary heart disease, which is maybe manifested as a clogged arteries, blood delivery to the heart is going to decrease. This is causing coronary heart disease, so the heart itself is not getting enough oxygen, and that causes pain called angina pectoris, which sometimes is the prelude to a heart attack. A heart attack or myocardial infarction, you should know some of the signs and symptoms: chest pain radiating to the left arm, tightness and pressure in the chest, difficulty breathing, nausea, vomiting, dizziness, fatigue. In women, some of these signs and symptoms may be different. There may be stomach cramps, heavy perspiration, anxiety, pain on either arm. So you should be aware of the differences between signs and symptoms of myocardial infarction in women versus men. So you should be able to explain some of the changes to the heart that take place during aging, the increase in the afterload especially, which may cause hypertrophy of the left ventricle. Some of the treatments to reverse coronary heart disease due to plugged arteries, that may be opening up the arteries due to angioplasty or some surgical procedure, for example. Angina pectoris is the pain that is felt in the heart due to plaque, which prevents oxygen from blood with oxygen from irrigating the heart itself. You should know some of the signs and symptoms of myocardial infarction, both in men and women. How does coronary heart disease and increase in afterload result in ventricular hypertrophy? That's because the left ventricle has to work harder, pump with more force, and the heart is a muscle. So when you work the muscles are going to increase in size. Therefore, the hypertrophy of the left ventricle. Which parasympathetic nerve innervates the heart? We talked about the vagus nerve doing that. And what is the effect of acetylcholine on the heart muscle? Remember we said acetylcholine is the parasympathetic neurotransmitter, which means that the heart rate is the effect of this nerve will be to, of this neurotransmitter, will be to lower heart rate. Okay.